Today, class of EC, it took us 3 hours time. Peptic ulcer. And since it is an EC class, so here you will be observing the class, and after the end of the class, you will be given 3 questions. One is what you have observed, and next is so what, and the third one question, what next. In what you have observed, you have to describe what happened during this time. And so what, you have to analyze and you have to make your sense. And what next? Take effective next steps, learning steps particularly. Okay? And what you have observed. So you have to, there are a lot of things you have to explain. What was your experience during this session? You have to mention it in your reflection. What happened, focusing on the actual facts only. What did you particularly notice? What worked well and what didn't? So anyway, I am not going to read it. So these are the things you have to know. If you want to know, this will be there. You make it copy, and then since you have to write and submit to us. So accordingly, you write this, write your reflections and submit. What next? So you have to, definitely you have experienced that there were 3 questions, what to write. So now you will be having certain points. So these are the points which you have to explain. Okay. So now I am straight away coming to, actually in ECE class, we place a problem, a case study. One person came with such and such problems, and such and such things, investigations made, and after that, what would be your diagnosis? Then if it is your diagnosis, then how can you relate it with physiology? Okay, so there will be certain questions. Say for example, peptic ulcer, when it will be diagnosed, either it is this peptic ulcer, either it may be gastric ulcer or it may be duodenal ulcer. Because both the ulcers are together, we call it peptic ulcer. So when it is diagnosed, it is a gastric ulcer. Then next question comes, what is the pathophysiology? How it is created? How it is caused? And since it is mainly due to excess hydrochloric acid formation or disruption of protective layer of the stomach or infection by H. pylori. These are the 3 main causes, and another cause is using non-inflammatory, non-steroidal drugs, NSAIDs. So these are the main causes. So then question may come, how hydrochloric acid is formed in the stomach? What are the different phases of gastric acid secretion? What would be the consequences of, or what are the complications of peptic ulcers? So there are so many questions can be asked, and you have to write the physiological reasons. Okay. So now let us see what is peptic ulcer. Peptic ulcer is a term referred to breakdown of the mucosal epithelium of the stomach and or duodenum. So what is peptic ulcer? Breakdown of mucosal epithelium. Breakdown of, cause may be different. Breakdown of mucosal epithelium, either of stomach or next to stomach where there is duodenum, so or duodenum. Both are peptic ulcer. When it is, this ulcer is present in stomach, we call it gastric ulcer. When it is present in duodenum, we call it duodenal ulcer. So peptic ulcer, two types, gastric ulcer and duodenal ulcer. So this is the inner lining of mucosa. Inner lining is, this is the mucosa, this is muscularis mucosa, submucosa, and this is the muscular coat, muscle layer. So here is the ulceration, it penetrated up to submucosa. So this is what, this is the stomach and this is the histological structure. So this is the mucus layer, here the epithelial, this is the epithelial, these are the epithelial lining, this is gastric glands, gastric pit, so this is gastric pit and these are the gastric glands. So these glands produce pepsin, produce hydrochloric acid by different cells, produce gastrin. So there are different cells, they produce different, either pepsinogen or hydrochloric acid. Okay, and they also produce somatostatin. I will discuss what their functions. There are G cells, they will produce secretin, gastrin. So this is peptic ulcer. This is what? Mucosal lining. So this lining is disrupted. This lining is disturbed and cause ulceration. And it has penetrated up to submucosa. This is submucosa. So these are the necrotic cells. And cause, what are the cause? Main cause is H. pylori, gastric acid, pepsin and NSAID. These are the most prevalent cause of peptic ulcer. And 80 to 90% case of peptic ulcer are caused by H. pylori. Then this is the second cause is this. Second cause is painkillers. Okay. Both of them causes increased gastric acid secretion, increased pepsin secretion. Okay, let's come into this. Peptic ulcer is characterized by there will be discontinuation of inner lining, mucosal lining for at least Devrata, na? Devrata. But 5 millimeter, more than 5 millimeter. The ulceration, discontinuation or removal of damage of mucosa, how much? Minimum 5 millimeter. And it should penetrate, the ulcer should penetrate up to submucosa. And in worst case, not only it can penetrate submucosa, it can penetrate into next to submucosa what? Muscular coat. Even it may extend up to serous coat. And what will happen after that? Lot of blood will be coming out and will be entering into the peritoneum. and it will cause peritonitis. So there is chances of death. Okay, so not only blood will be coming into the peritoneum, it will be coming into it may come into the lumen of the stomach, and there will be, this is called melena. So, and it will, when melena, this blood will be passing through the next portion of the GI tract, it will be converted into black tarry substances. It will look like tar. Okay, you have seen tar used in carpeting the roads. So, this sort of color it may produce. So, ulcers are defined as breaks in the mucosal surface 5 mm in size, more than 5 mm in size, with depth to the submucosa. It may extend into the muscularis mucosa layer of the gastric epithelium. It usually occurs in the stomach and proximal duodenum. So, if you look into the proximal, I am coming later, gastric ulcer most commonly located in the lesser curvature. Most commonly located in the lesser curvature, whereas duodenal ulcer is seen in the duodenal C shape, and where ampullar bladder at the bending, descending part of the bending. So, before that there is some area which is not having any substance that can neutralize the hydrochloric acid coming through from stomach through chyme. So, that's why this area, early part of the initial part of the duodenum is most prone for duodenal ulcer. Later part is having secretions from pancreas, secretions from bile, so they will neutralize these acids. So that's why it can, the later part of the duodenum is not usually affected. And the epidemiology, see that lifetime, during your lifetime, there is risk 5 to 10% risk. So you may suffer, chances of suffering is 5 to 10% during your lifetime. And duodenal ulcers are 4 times more common than gastric ulcers. How many times? 4 times more. Prevalence increases with age, with a peak prevalence as 28.8%. Among patients with peptic ulcer disease, the prevalence of Helicobacter pylori has been reported to range from 80 to 90%. So, whenever you will find a case, you think it definitely it will be every chance of the patient is suffering from H. pylori infection. And what are the causes of peptic ulcer? So, these are the common cause. Most prevalent cause is this, and as I said, second cause is what? And this is other medications. And the rare causes are Zollinger-Ellison syndrome. What is this syndrome? In this syndrome, one tumor is formed in pancreas. This tumor can also be formed in the wall of the stomach. So what this tumor do? They secrete lot of gastrin, and we know increased secretion, gastrin causes what? What is the role of gastrin? It increases hydrochloric acid secretion as well as pepsin secretion. So more than the amount required, it will be coming from the gastric mass. Okay, so it will produce definitely this, when it will be there, definitely the patient will be suffering from peptic ulcer. And what is this malignancy in stomach? This may cause this stress is another very important. As I said in our GRD classes, the people who are always in hurry, worry and curry, they suffer GERD and they also suffer peptic ulcer. So because the high officials, they are under tremendous work pressure, anxiety. Okay, so this will, you see, when your exam is at doorstep, so you feel anxiety. So this anxiety, when it is that you feel nauseated, you don't eat like eating, you don't like eating. So this sort of thing, excess acidity is there. So it is because of anxiety or tension, stress. Radiation therapy, Crohn's disease, chemotherapy, viral infection, these are the other causes. Most important causes are these. Okay, I will remember this thing. Fine. Let us see the etiology. So first thing is how it is created. So we know inner lining of the stomach, mucosa, is protected by a mucus coat, thick mucus coat. And see the nature of this coat. This is the mucus coat. This is the actual lining of the inner lining of the mucosal lining. This is the mucosal lining. And these cells lining the mucosa, these cells secrete what? Mucus, thick mucus. And this mucus also contain high amount of bicarbonate. So one is mucus, another is bicarbonate. And what is the pH of this? Since it is, what would be? It will be 2 or 7 or 8, 9, like that. So here, see, gastric lumen pH is 2, means very acidic. And this is the layer, mucus layer. So if acid wants to enter, kill these cells, they have to enter from here to here. And it has to pass through this barrier. And this barrier is alkaline. So if hydrochloric acid wants to enter, then it has to pass through this barrier. While passing through this barrier, it will be neutralized. So it cannot affect this lining. By any means, if it is able to break this barrier, and definitely when come the hydrochloric acid and pepsin, when comes in contact with this, the cell will be digested. These cells will be digested. Not only this, it will enter into the submucosa, and it may destroy the capillary. Immediately, there will be bleeding. And this bleeding will come into the lumen, will create melena. And when these are digested even further below, towards the surface, then there will be perforation of the wall of the stomach. The barrier, everything. Now, what are the causes? What causes the disruption of the barrier? What are the important factors that disrupt this barrier? One is infection by H. pylori. So, H. pylori bacteria, they form a colony in the mucosal surface. When it forms this colony, the bacteria increases hydrochloric acid by inhibiting somatostatin. So we know gastric glands also secrete some local hormones. Somatostatin is one of such hormones. The function of somatostatin is opposite to gastrin. Means there should be always a balancing mechanism. One will increase, another will decrease. Somatostatin is there to decrease hydrochloric acid secretion and to increase the bicarbonate secretion and to increase the mucus secretion. So when bacteria increases, it stimulates, this bacteria inhibits somatostatin. So what will be there? The inhibition will be withdrawn. Normally the inhibition created by somatostatin on hydrochloric acid secretion. So this will be withdrawn. So immediately what will happen? There will be increased production of hydrochloric acid. Okay. So H. pylori in this way disrupts mucosal bicarbonate barrier. Another cause is alcohol. Another cause is bile salts. Bile salts are secreted in intestine. So how it can come into stomach? So these patients, they usually vomit. On gastritis patient, GERD patient, they vomit. There is nausea, they used to vomit. So this vomitus also comes from intestine. And this intestinal juice, in the intestinal content, there is bile and bile salts. So along with food, along with vomitus, these bile salts can enter into the stomach. So now these bile salts can cause disruption of the barrier, mucosal barrier. And third is NSAIDs. So we have already explained it, what is this mechanism. In it, the NSAIDs actually, see, like somatostatin, somatostatin inhibits what? Hydrochloric acid secretion. Prostaglandin also inhibits hydrochloric acid secretion. Now what happens? These drugs inhibits prostaglandin. Now, if this drug inhibits prostaglandin, so prostaglandin action was what? Inhibition of hydrochloric acid secretion. So this will be withdrawn. There will not be any inhibition from prostaglandin because prostaglandin secretion is inhibited by this drug. So as a result, what will be there? There will be increased secretion of hydrochloric acid, increased secretion of pepsin. Now this increased pepsin, increased hydrochloric acid can disrupt the mucosal lining. Second is hypersecretion of gastric acid. This hypersecretion of gastric acid called hyperchlorhydria. And what is the opposite? Achlorhydria. No secretion of hydrochloric acid. Less secretion of hydrochloric acid. This is called achlorhydria. Okay? Achlorhydria. So you may get questions. Achlorhydria. When achlorhydria is seen, when hyperchlorhydria is seen, what happens when hyperchlorhydria is created? So this sort of question may be asked either in the Viva or there may be in short question, there may be question. Gastrin, increased secretion, pepsin. So it has been seen some patients or some individuals are having two type of pepsin. Pepsinogen 1 and pepsinogen 2. Pepsinogen 1 is very risky. The person who is suffering from, who is having pepsinogen 1, where is this pepsinogen? It causes maximal hydrochloric acid release. Okay, and its efficacy when we take food, pepsinogen is secreted. And the action of pepsinogen is much more than the pepsinogen 1 is much more. The response of pepsinogen 1 is much more than the pepsinogen 2. And this helps in creation of peptic ulcer. And I already told, say in this case one tumor is formed, gastric noma. It may be formed, this gastric noma may be formed in pancreas as well as in stomach or in any other part of the GI tract. They will produce gastrin, and that gastrin will cause increased secretion of hydrochloric acid. And there are mast cells. The mast cells release histamine. And histamine is another factor like acetylcholine, histamine, gastrin. All these increases hydrochloric acid. When there is systemic mastocytosis, more production of histocytes. So they will produce more histamine, and this histamine will cause increased production of hydrochloric acid. So I may ask, what is the role of histamine in gastric secretion? Gastric outlet obstruction means the sphincter. What is the sphincter in between esophagus and stomach? If this is constricted, obstructed, the stomach content will not be passing through. So what will happen? Inside lot of hydrochloric acid will be secreted, lot of pepsin will be secreted, so they will cause disruption of the membrane, mucosal membrane. Gastric outlet obstruction, the pylori stenosis, and it is already been said chronic anxiety and stress, hurry, worry and curry leads to peptic ulcer by causing hyperchlorhydria. And this is the Zollinger-Ellison, this is the tumor. Non-beta cells of pancreas, it is producing gastrin. Now this gastrin is stimulating pancreatic cells or parietal cells. They secrete more hydrochloric acid and they causes ulceration. Helicobacter bacteria infection. Let us learn about this infection. What is this? So this bacteria was identified by Robin Warren in 1981, and when doing biopsy, he found that lot of colonies of H. pylori, a typical pattern of bacteria he first identified. Spiral urease produce, spiral, see this, isn't it spiral? So this sort of bacteria, these are gram-negative bacteria, spiral bacilli, they do not invade cells. They remain outside the cells and causes urea, is break down urea into carbon dioxide and ammonia. So in the stomach we will get lot of carbon dioxide and ammonia. Normally it is absent. Ammonia is absent. So whether somebody is suffering from H. pylori infection, there is H. pylori infection, it can be diagnosed by how? By simple test. Only the gas coming out from stomach, it will be analyzed by a method. So if presence of ammonia is found, that means the patient is suffering from H. pylori infection. This bacteria is responsible for 90% of duodenal ulcer and 70 to 90% of gastric ulcers. I already told earlier. And these are more prevalent among what? Lower socio-economic class, people of low socio-economic class, SES people, low SES people. The organism has a wide spectrum of virulence factors allowing it to adhere to and inflame the gastric mucosa. Okay. I already told it produces carbon dioxide and ammonia. And the second cause is, as already explained, what is this? Non-steroidal anti-inflammatory drugs. So they at the second, after H. pylori, their position is second. Second to H. pylori in creation of peptic ulcer. The secretion of prostaglandin normally protects. What is the function? It protects the inner lining. But when this prostaglandin is inhibited by their prostaglandin secretion is reduced because of this drug. As a result, action of prostaglandin will not be there, so there will be more hydrochloric acid secretions. Drug induced and others that cause peptic ulcer. Apart from non-steroidal anti-inflammatory drugs, there are corticosteroids, biphosphonates, potassium chloride, and fluorouracil. These are also responsible for PUD. Smoking, alcohol, hypersecretory environment in the following conditions. So these conditions we have already discussed. Now see, we have arranged the factors. These are the aggressive factors. They will cause increased gastric acid. The increased gastric acid secretion will cause peptic ulcer. Increased pepsin secretion will cause peptic ulcer. Increased helicobacter infection will cause peptic ulcer, and this will also cause GERD. And they will prevent ulcer. What are these? Prostaglandins, mucosal blood flow, mucus gel layer, bicarbonate ion, epithelial tight junctions. So in the epithelium, so they are adhered to one another using tight junctions, so that they are not by any force, they cannot be displaced. So these tight junctions are also protective in nature. Regeneration, another thing is, as I said in our earlier classes, all these epithelial cells are not permanent. After some time they will also be displaced and they will undergo apoptosis. Okay, so when a cell is epithelial cell coating the inner lining, they will be damaged, so it will be immediately replaced. So these are the preventive mechanism. Now the features, very important. So you go through the features. Means signs, symptoms. What are these? In most of the cases, ulcer is located in the duodenum, as I said, and usually above ampulla or water. Gallbladder, left lobe of liver, right lobe of liver, bile is coming, storing here. When food is taken, it is contracted, so bile is entering through ampulla of water into the duodenum. So pancreatic juice also through pancreatic duct, through ampulla of water entering into the duodenum. So food from here it is coming into entering into the duodenum. So this food is having lot of hydrochloric acid, but not neutralized. Here there is no scope of neutralization. Since these bicarbonate ions are alkaline substances are present here, starts from here. So this part is not having adequate amount of bicarbonate ion to neutralize the hydrochloric acid. So for this reason, this part of the duodenum is mostly affected. The earlier part, this is the reason why earlier part is mostly affected or duodenal ulcer is seen in this part. So, the main features of peptic ulcer is epigastric pain. Epigastric pain, typically pain is experienced in empty stomach. And when you take food, it is relieved, the pain is relieved. But again, if you are having gastric ulcer, you will feel pain again within 30 minutes, within half an hour. But in case of duodenal ulcer, it may take 2 to 3 hours to initiate the pain. So after taking food, when immediately you feel pain, within half an hour feel, that means you will be suspecting there is a gastric ulcer. If it is delayed by near about 2 hours, then it is duodenal ulcer. Anorexia. Anorexia means not liking to eat food. Abdominal fullness. Always your abdomen will remain, you will feel my abdomen is full, I am unable to eat. So this abdominal fullness is, so these are the main symptoms. If untreated, there may be hematemesis, means vomiting, blood vomiting. With vomiters, there will be blood. Means there is perforation. Means there is ulceration. And blood vessels is injured. In the submucosa, there are blood vessels. The infection already, erosion also gone up to that level. Melena, nausea and vomiting due to pyloric obstruction, peritonitis. So, if you don't undergo treatment, if you are having the symptoms but you are not taking care of, so what would be the consequence? Question. What would be the consequence? So, there will be hematemesis, melena, nausea, vomiting, and peritonitis. So, there is a common side symptoms for both peptic and duodenal ulcer: burning abdominal pain, epigastric abdominal pain, and in 20% cases, the pain will be more in the right side. Okay, bloating. Bloating means abdomen feels full and tight. And abdominal fullness, anorexia, nausea, vomiting, weight loss, hematemesis, melena, succussion splash. In a bottle, half filled, a bottle is half filled and cork is closed. Now, if you change the position, you will hear a sound. When we eat, after eating, when we change our position and we eat a lot of water, so you will feel a sound, something is moving enough. So that is called succussion splash. Warning symptoms means immediate attention should be taken. What are these warning? Unintentional weight loss, progressive dysphagia, difficulty in eating, overt gastrointestinal bleeding. You can see the blood, fresh blood. So this is called overt gastrointestinal bleeding, iron deficiency anemia, recurrent emesis, recurrent vomiting, family history of upper gastrointestinal malignancy, cancer is there, GI tract cancer, history is there. So these sort of patients should immediately go to visit the doctor, visit the clinic. Okay. Physiology of gastric acid secretion means how hydrochloric acid is formed. So I am giving a case, he is having such and such problem. Why it is created? You will say this is, what is the offending agent? You will be say more hydrochloric acid. I am not telling, it is, you will be identifying the patient is having such and such symptoms. You will face one question like this. One patient came, he is having such and such complications, such and such symptoms. Okay, then what is your diagnosis? So you will say either peptic ulcer. So then symptoms I have given. So you will say this is peptic ulcer. Then question will be asking, I didn't tell anything. Now what is the next question? What is the offending agent? You will say hydrochloric acid. Next, how this offending agent is synthesized? Means hydrochloric acid production. Mechanism of hydrochloric acid secretion you have to write. Okay, and what are the different phases of secretion of these offending agents? That means 3 phases, 2 phases you have to explain. I have already explained in our class, gastric acid secretion, regulation of gastric acid secretion. So that phase you have to know. Here I don't have any scope now, but in brief I will tell hydrochloric acid secretion because any question can come from here. And I have seen your answer in hydrochloric acid secretion. Bogus. What you have written you don't know. See how hydrochloric acid is formed. Carbon dioxide, lot of carbon, it is highly active cell, lot of oxidation, lot of mitochondria is there, lot of oxidation is taking place, so lot of carbon dioxide will be produced. So this carbon dioxide combines with water and is converted into H2CO3. It means this reaction needs an enzyme. It is called carbonic anhydrase. Without this enzyme, this is not possible. Otherwise, the reaction will be very slow. So that will not satisfy. So we need an enzyme that is called carbonic anhydrase. So with this carbonic anhydrase, this will be converted into H2CO3. When this acid is formed, immediately it is dissociated into hydrogen ion and bicarbonate ion. Okay. Any one question you may expect. Okay. And this hydrogen ion is produced. Now this hydrogen ion will be released into the canaliculi and then into the gastric lumen. Now how this will be released? How this will enter from here to here? Because our cell membrane will not allow. So how to go? By forcefully you have to go. So their force means I have to spend ATP. So there must be a pump. So when there is a pump, we would need what? ATP. There will be breakdown of it. We will be needing energy. So at the cost of the ATP in this pump, through this pump, this will be excreted. And from the lumen, potassium in exchange, potassium will be entering from gastric lumen into this. So this is the pump. What is the pump? Potassium, hydrogen pump, ATPase pump. So there are drugs nowadays. There are drugs. If you go to any physician, you are having this sort of pain, acidity, immediately he will prescribe one proton pump blocker. This is the proton pump. So this is the, even over the counter, if you go and ask for, give me one pantoprazole or pan-40, pantocid. So these are this channel blocker. So when this channel is blocked, no hydrogen ion will be pumped, so no facility will be formed, so you will get relief. Okay, and one of the unique thing, if you use this drug regularly, then what will happen? You have blocked this sort of pumps. Lot of pumps are there. This is one pump. So lot of pumps. So all these pumps you have blocked. Now the body is very adaptive. It will create new pumps, which are not blocked now. So they will again start producing hydrochloric acid. That's why long-term use is not suggested. Okay. Now what will happen? What will happen to this bicarbonate ion? So chloride, where is the chloride? Now this chloride ion will be diffused here. Now this chloride ion and hydrogen ion will form hydrochloric acid together. And this hydrochloric acid is not formed within the cell. Why? Not formed within the cell? It would have destroyed the cell. Okay, that's why through different canaliculi, through different channel, hydrochloric acid is secreted into the lumen. Okay, now what happens? See, if this reaction goes on, what will be? More hydrogen ion will be released. At the same time, more bicarbonate ion will be released into blood in exchange. So you need more here you need more hydrogen ion, more acid. So where from this hydrogen ion will come? From the breakdown of this. So when it breaks down, hydrogen ion will be available here, and at the same time this will produce a lot of bicarbonate ion. Now this, what will happen? It will diffuse into the blood, and this is an alkali. So when you eat any food, there will be increased secretion of hydrochloric acid. And if you study your blood and urine, you will find your blood has become now alkaline. At the same time, your blood has become alkaline and your urine also became alkaline. This is called alkaline tide. Question is asked in annual exam, in final exam, in maybe this exam also you may get this question. What is alkaline tide? How it is created? What is the mechanism of formation of this alkaline tide? So you understood, all of you, what is alkaline tide? Understood? So you will face question. Now see, there are 3 pumps. While discussing hydrochloric acid synthesis, you have to mention 3 pumps. How many? 3. One is potassium hydrogen pump. Another is sodium potassium pump. Sodium potassium ATPase. Another is exchanger. Hydrogen bicarbonate ion is coming out from the cell into the blood. In exchange from the blood, chloride ion will enter into this. So this is called, this is an antiport. This is coming and this is going in. And this, so there is an antiport. There is 2 pumps. One is sodium potassium pump and another is sodium potassium hydrogen pump. So you have to mention about 3 pumps and their uses. And see, for regulation, acetylcholine, it through M3 receptor, it increases hydrochloric acid secretion. Gastrin also increases through this gastrin receptor, it increases this hydrochloric acid secretion. Histamine also increases GS, stimulating receptor, they will also cause increase in hydrochloric acid secretion. Whereas the gastrin, histamine, acetylcholine, all this causes hydrochloric acid, increased hydrochloric acid secretion. Whereas prostaglandin, it is having GI, means inhibitory. It it inhibits this enzyme. As a result, less cyclic AMP is formed. As a result, protein kinase is not activated, so pump is not operated. So this is the mechanism. Nerve is stimulated, means vagus nerve will be stimulated. The vagus nerve, stimulation of vagus nerve will cause, these are the path, it will cause increased secretion of hydrochloric acid from parietal cells. This pathway also increase secretion of hydrochloric acid. This pathway also, through this pathway, they also increase the hydrochloric acid. So whenever your vagus nerve is stimulated, there will be increased secretion of hydrochloric acid. Okay, so there are a lot of pathway by which it can create this. So how can you diagnose peptic ulcer? Peptic ulcer can be diagnosed by endoscopy. So this is the endoscope. It is inserted into through esophagus into the stomach, and it may go into early initial part of the duodenum also. So if any ulceration is there, you can see, you can find, and if any ulceration is there, so from there you can take a sample of the tissue for biopsy. So from this biopsy you check whether there is any H. pylori infection is there or not. So immediately it is checked. So if there is any H. pylori infection, so there should be double treatment. One treatment for H. pylori, another treatment for treatment of excess secretion of hydrochloric acid. So that means that blocker, proton PPI, in short we call PPI, PPB, proton pump inhibitor, I means inhibitor. So we will be our hydrogen blocker, hydrogen receptor, H2 receptor, not hydrogen, histamine receptor. So histamine, we have seen histamine increases hydrochloric acid production. So if we take, see in the market you will find famotidine, ranitidine, these are H2 receptors, blocker, means histamine is blocked, so hydrochloric acid secretion will be less. So these are the kits available for H. pylori identification, and breath test, blood test, stool test. By this test you can identify the presence of H. pylori. And lifestyle modification. What are the modifications? And we say there is how much these are effective. These modifications are effective, it is doubtful, though it is suggested. Rest, relaxation, good sleep, diet indication is balanced, has to take balanced diet, frequent small meals, fiber containing diet, and vitamin E and dietary fatty acids, fatty diet. And contra indication is caffeine not suggested, and spices, alcohol not suggested. And these are the anti-ulcer drugs. As I said, there are different groups. One is H2 blocker. This is H2 blocker, and this is PPI, omeprazole, pantoprazole, and these drugs actually blocks acetylcholine. Means when vagus nerve is stimulated, it will not be able to create more secretion of hydrochloric acid if you take these drugs. Okay, and these are prostaglandin analog. These are also available now. So prostaglandin inhibits hydrochloric acid secretion. So this prostaglandin analog can also be used. And gastrin blocker, this is, though it is suggested, probromide. These are not available in India. In America it is available. One tablet costs 23,000 rupees. That's why it is not marketed in India. And even then after purchasing by this much of money, its efficacy is also doubtful. So why you should spend this much money? And some other, already, see, my stomach has produced already some hydrochloric acid. So it has to be neutralized. How it can be neutralized? By using these antacids. Marketed in the these antacids will be having bicarbonate, sodium bicarbonate. These are available in sachets. So in a glass of water, you add these sachets, the content of these sachets. So there will be effervescence. You drink it. So already the acid that has already been formed, that will be neutralized. And sucralfate. Some sucral is available, liquid. So it creates a layer on the surface of the ulcer so that you don't feel so much of pain. And anti-helicobacter drug, what are the drugs available? These are the antibiotics, amoxicillin and clarithromycin. So combination sometimes only this is suggested, and sometimes combination of antibiotic is also given. This is ulcer. Okay, and this is antral region, the gastritis.